So today we will take dermatology, and the very first thing is about the basic, the histology or the epithelium of skin. And here you have to remember one word, that it is keratinized. Good morning, Shanawaz bhai. Good morning. So very important thing is keratinized, because the usual thing, like when we discuss about epithelium of esophagus, oral cavity, or vagina, we used to say stratified squamous non-keratinized, right? So here you have to remember the word keratinized. Clear? So this is very important here. So stratified squamous keratinized, right? So this is like this. At other places it is non-keratinized, but here it is keratinized. Now coming to the layers of the skin, the outermost layer is corneum, and this is the outermost layer. Then deep to that is lucidum. Now at many places you might have found that there are only mention of only 4 layers. That's so because this lucidum is not present everywhere. It is present only in palms and soles, right? So this layer is not present everywhere, and this you need to remember in terms of exam. So stratum lucidum. Deep to that is stratum granulosum, which is also known as granular cell layer, because it contains keratohyaline granules, right? So it contains keratohyaline granules, and therefore we use the word granular layer, right? So because of these granules. Then the next layer is stratum spinosum. Now spinosum means something like spines. So here there is desmosomes, which gives a spinous appearance. So this is spine, the stratum spinosum, or the prickle cell layer. Now these desmosomes actually help in keeping the epidermal cells together, right? So these desmosomes are, you can say, a sort of connecting protein. And the last and the deepest is stratum basal. As the name suggests, they are at the base. Clear? So these are the layers of epidermis, right? So this is more specifically epidermis, because deep to that we have dermis, right? So corneum, lucidum, granulosum, spinosum, and finally basal. And you can see one thing, that the cells, they are so densely packed. Clear? There is no gap. All the cells, especially in spinosum and related to the basal also, so everywhere the cells are very densely packed, and there is no gap as such. Clear? Now why I am telling you like this, because when we will take pemphigus, we will take this fact again. Clear? Now this part is known as retiridges. Okay, these are retiridges, and this is papillary dermis. So at times you might get these words. Anyway, so these are the 5 layers of epidermis which one should know. Then there is one term, acantholysis. Now as you know, the word lysis means destruction. So what is happening here, as I already told you, that all the cells of the epidermis, they are very tightly packed. There is no gap as such. But what happens, at times there is a gap in between these cells, and then it is known as acantholysis. So this is loss of connection or coherence between epidermal cells, and this is seen in pemphigus. And one is foliaceous, and another is the important one, vulgaris. Now in these both of these conditions we will see acantholysis, but the only difference is in terms of location. In foliaceous we see in upper part below corneum, right? So it is known as subcorneal, right? So the word corneal is stratum corneum, not cornea. And vulgaris we see suprabasal, that is lower part, right? So this is lower part, and we write suprabasal, means above the basal layer. So acantholysis has to be remembered only with pemphigus, no other entities, right? And then you can see here, we can see so many gaps. These white areas, all areas of acantholysis. Normally this should not be seen, but here you can see plenty of these gaps. So this is all acantholysis, right? So I think that might make you clear what actually acantholysis is. So this is acantholysis. And to be from exam point of view, please remember pemphigus. Please remember pemphigus. Clear? Then moving forward to nail, pterygium of nail. It is a feature of Lichen planus. Now onycholysis, this is seen in psoriasis. It can also be seen in injuries, or it can be seen in fungal infections, right? So this is onycholysis. Then Eldrick measlines, I think most of you must have studied in forensic. This is arsenic poisoning. Then oil drop, pitting of nails, it has to be remembered for psoriasis. And third point is all of course onycholysis. So in psoriasis you can see all these findings. Then tinea angum, that is the fungal infection of the nail, it affects nail plate. Then there is one condition where we see spoon shaped nail, there is a depression like this. So this is known as koilonychia, and this is classically seen in iron deficiency anemia in females, and that is a component of the Plummer-Vinson syndrome, right? So apart from iron deficiency anemia, there is post-cricoid web which leads to dysphagia. So this is Plummer-Vinson syndrome. Then certain sexually transmitted conditions, like one is chancroid, and this is caused by Haemophilus ducreyi. And here one need to remember that the ulcers are multiple and painful, right? So if we talk about the features of ulcers here, right, and we need to differentiate it with the syphilis, primary syphilis, that is chancre. So one point is about ulcers number, it is many, it is one here. Then second is pain, it is present here, it is absent here. Then third is induration, this is absent here, this is present here, right? So this is how we clinically we can differentiate the ulcer of chancroid with primary syphilis. The classical thing is the painful ulcers of chancroid and painless ulcers of syphilis. And of course I think most of you must be knowing this is caused by Treponema pallidum. Clear? So I think this is not a difficult thing to remember. So organism. Clear? So these are two important conditions. Then there is one condition that is LGV, that is lymphogranuloma venerum. It is caused by Chlamydia trachomatis, and here the patient presents with buboes, which are actually enlarged lymph nodes, and there is a classical groove sign, right? So the inguinal and the femoral lymph nodes are enlarged, and the region of inguinal ligaments converts into a groove. So that is a classical groove sign for LGV. Now this is considered as a in genital ulcer disease, but at the time the patient comes to us, that ulcer stage has already passed away. So mostly he comes to us with enlarged lymph node. Clear? Then one condition is donovenosis, which is caused by Calymatobacter granulomatosis, and this is not seen in India. Clear? So it is not seen in India, and we can see Donovan bodies. Apart from this, there is one more genital ulcer disease, and that is herpes genitalis, which is caused by herpes simplex virus, of course. So HSV, and here there are small vesicles which are in group, which are extremely painful, and there is an red base, so erythematous base. Clear? So this is a classical grouped lesions of herpes genitalis, very easy to identify. Now these are about genital ulcer disease, right? So this group is genital ulcer disease. They present with ulcers. So this is the main heading, and we have discussed 5 entities under this, right? So this is first, this is second, this is third, this is fourth, and this is fifth. In the another group is urethral discharge disease, right? So another group is urethral discharge disease. We can write it group B. Okay, we can group A. So there are two. These are all conditions discussed under sexually transmitted diseases. So in urethral discharge disease, we have 2 entities. One is gonorrhea, right? And the second is non-gonococcal urethritis. This is caused by, of course, Neisseria gonorrhoeae, and this is mostly caused by Chlamydia trachomatis. The main difference is in the type of discharge. Here we have in purulent discharge, right? So this condition presents with thick purulent discharge. Right? So if we write about discharge here, this discharge is of course per urethral, through the urethra. Here it is thin, watery. Clear? So this is how clinically we can differentiate. This can be, now coming to the treatment, we can give azithromycin 1 stat, right, 1 gram stat, and we can give ceftriaxone here. Okay. So anyway, this is in short about urethral discharge diseases. Now moving forward to scabies, the incubation period is 4 weeks. This is caused by Sarcoptes scabiei, the mite, and the characteristic the pathognomonic lesions are the burrows. You can see the burrows here, right? So these are all burrows, clear? And this is present in the outermost layer, that is stratum corneum. So this is outermost. Now in adults, it usually affects the areas below the neck. Clear? So it can affect web spaces, groin, like if you can see here, it is affecting the web space, right? But in children's or in infants, it can affect the upper part of the body as well. So scalp and face can be affected. Here in adults, scalp and face is not affected. So scalp, face not affected, right? But in infants it can be affected. So that is one major difference. Now treatment wise, treatment is with topical agents. Clear? So this is 5% permethrin or BHC. Clear? There is one oral drug, but remember this is not the drug of choice, right? So this is not drug of choice for simple or ordinary scabies, but it is used in Norwegian scabies, which is the most severe, or in fact most infectious. Clear? You can write most infectious. That's very important because there is so much of crusting and patient does not itch, so no dislodgement of mite, and therefore he becomes very infectious. Now for this Norwegian, we need to give topical plus ivermectin. Clear? So this is in short about scabies. Then coming to psoriasis, you can classically see it is affecting the extensor aspects. Here it is the shin area. Clear? And we can see classically see the silvery scales. So the moment you see silvery scales, the answer has to be scabies. Psoriasis. Then there is one Cobner's phenomena, which states that in a normal skin, if there is any injury, it will develop lesions. Right? So this is Cobner's phenomena. Like injury can be in the form of tattoo or ear piercing. So that will all lead to the lesions. And if we are discussing about psoriasis, it will be psoriatic lesions, right? So traumatized skin areas develop psoriatic lesions. Now this is not exclusive, right? So this is non-specific. It is not exclusive to psoriasis. It can be seen also in Lichen planus or even in vitiligo. Now regarding microscopic features of psoriasis, one must remember two terms at least. One is Monroe's microabscess and the second is Cogos spongiform pustule, right? So Monroe microabscess and Cogos spongiform pustule. So just remember two terms for histology of psoriasis. So Monroe microabscess and Cogos spongiform pustule. Now psoriasis can involve the bones as well, and that is the arthritis mutilans. And if we take X-ray, we will see a classical pencil in cup deformity. Clear? So this is tip of middle phalanx, and this is the base of distal phalanx. So it becomes cup shape, and this becomes pencil tip, and this becomes cup. Clear? So classical pencil in cup deformity, very easy to remember. Then we can see one Auspitz sign, where if we try to remove the scales, that results in pinpoint bleeding. Clear? So here there is pinpoint bleeding. So rubbing of the skin leading to removal of scales, that results in pinpoint bleeding. That's Auspitz sign. And treatment is by PUA therapy, that is Sorlin plus ultraviolet A rays. Then moving forward to pemphigus, which the classical condition is pemphigus vulgaris, which is an autoimmune disease. Now when we say autoimmune, it means the immune system is directed against the normal tissues of the body, and here there are antibodies which are directed against desmoglein 3. Clear? And this desmoglein 3 is present in desmosomes, and if you remember stratum spinosum, this is present in stratum spinosum, where it keeps the epidermal cell together. Now if this is broken, the epidermal cells will move apart, and that is known as acantholysis. Clear? So there are antibodies against desmoglein 3, and what clinically we'll see, the bulli are flaccid, right? So flaccid bulli are there, like so, and they rupture at times. So flaccid bulli with rupture easily, and you can see the denuded skin. And apart from this, there are oral mucosal lesions as well. Now coming to the histology, we have already discussed about acantholysis, and you can classically see so much of gap between the epidermal cells, which normally should not be seen. So this is all acantholysis. Clear? This gap should not be present. So this is all acantholysis. And since if you look at the location, this is suprabasal. Clear? So this is suprabasal, because this is the basal layer. Clear? So we can classically see that the acantholysis is just over the stratum basal, and sometimes what happens, the basal layers, they remain attached something like this, and this is known as row of tombstone appearance. So this is row of tombstone appearance. Clear? So very easy to identify in picture, and the clinical sign of acantholysis is actually Nikolsky sign. So this is clinical, you can say, demonstration of acantholysis. So what you will do, you will give a tangential pressure through the normal skin, and that this will lead to peeling of the skin. So that's Nikolsky sign, very important and very specific for pemphigus. Now on DIF, that is direct immunofluorescence, right? On DIF you can see a fishnet pattern, right? So this is fishnet, again very important for pemphigus. Clear? So I think it's a very important condition, and most of the time we have question from this area. Now pemphigus has to be differentiated from pemphigoid, and just look at the arrangement of the blisters here. The blisters are so tense. Clear? And we discussed that in pemphigus the blisters are flaccid. So a very important clinical difference. The moment you see the blisters which are tense, and we can easily say that's bullous pemphigoid. And here it's also an autoimmune condition. So here the antibodies are against BP1, BP2. So bullous pemphigoid 1, bullous pemphigoid 2, very easy to identify. So the bully are tense, and here one important thing is that the location of bully is subepidermal, right? So when I say subepidermal, so suppose if this is the normal epidermis like this, so the acantholysis, the blisters are in the, this is the area of blistering just below the stratum basale. Okay, so this is stratum basale, so just below the stratum basale. Clear? So this is subepidermal bully, whereas in pemphigus it was intraepidermal suprabasal. So you can write intraepidermal because it is within the dermis, of course suprabasal. Fine. So these are 2-3 important differences between pemphigus and pemphigoid. And since here there is no acantholysis, please note it down, there is no acantholysis, therefore the clinical representation of Nikolsky sign will also be negative. So these are 3-4 important differences which one should know from exam point of view. Now moving forward to dermatitis herpetiformis. Now the word herpes is here, but it is not related to herpes virus. So please don't get carried away. Not related to herpes virus. Now this condition is actually a skin condition, right? But it is also associated with one GIT condition, and that is gluten sensitive enteropathy, which is also known as celiac sprue or celiac disease. Clear? So I think most of you must be knowing that there is protein gluten in wheat, barley, rye, which causes this problem. So this skin condition is associated with this GIT condition. Clear? And when we do DIF, so DIF in this case will show you granular deposits of IgA. Clear? Now this is all papillary dermis. Okay, so we can see the granular deposits of IgA. Now treatment wise we give Dapsone. So dermatitis herpetiformis we need to give Dapsone, and the response is dramatic. The condition improves very well. And of course for gluten sensitive enteropathy, avoid gluten containing cereals like wheat, barley, rye. So don't give all these. So what we can give? We can give rice, we can give maize. Clear? So this is in short about dermatitis herpetiformis. Then moving forward to lichen planus, which is characterized by 5 P's. And what are they? Plain, papule, pruritic, purple in color, and polygonal. So just remember these 5 P's of lichen planus. And of course in nail we will see pterygium. So you can add this as well. Clear? And pruritic means there is itching. Purple is like you can say violet color. Then polygonal is different shapes. And then plain means the top is flat. So flat topped. Now what we will see in microscopy, there are a couple of points which you need to remember. One is civate bodies, right? So just remember the terms. One is civate bodies and second is Max Joseph space. So just remember these two terms, right? So civate bodies and then Max Joseph space, and there is degeneration of the basal layer, right? So these are few terms related to lichen planus. And then we can see white lacy markings in the oral cavity, and on the top of the lesions we can see Wickens striae. So we will see usually we can see white line like on this lesions, and this is known as the Wickens striae. Fine. So this is lichen planus. Then moving forward to Pityriasis rosea, and here we can see there are few terms which you should know. One is of course the herald patch, which is the biggest in size of all the rashes, right? So you can see the herald patch. Then there is annular collarette of scales. So there is collarette of scales, and these scales are actually like, if this is skin surface, this is skin surface, the scales are like this. Outer part they are attached to skin, and this is outer part, and inner part, inner border is free, right? So inner border is free. So this is collarette of scales, and the consistency is like cigarette paper. Clear? And one more thing which you need to remember here, these are the lesions are arranged like this on the back, right? So this is known as Christmas tree appearance. Fine. So these are 3-4 terms which you should remember for Pityriasis rosea. Then moving forward to tinea, that is fungal infections. There is one condition that is known as athlete's foot, but it does not mean that it will be seen only in athletes. It can be seen in any person in whom there is excess sweating within the web spaces of toes or foot, right? So if there is excessive sweating, that we call hyperhidrosis. Now hydrosis means sweating. So this presents with moistness, and that causes fungal infection. Patient comes to us with severe itching. Then onychomycosis is the tenuangum, which is ringworm of the nail plate, right? So this is all same entities, and this is fungal infection of the nail plate, right? So we can use different words. Then dhobi itch or jock itch is actually tinea cruris, is affecting the, this is medial upper thigh. So this is tinea cruris. Then there is one condition, that is tinea versicolor, or also known as versatile color. This is caused by Malassezia furfur, and this is tinea versicolor or Pityriasis versicolor. And on histology we will see spaghetti and meatball appearance. Clear? So this is in short about tinea versicolor. Now moving forward to acne, which is because of obstruction of pilosebaceous ducts. So pilo is actually hair, and sebaceous is sebaceous gland. So when usually we see that the suppose if this is the hair follicle, right? So if we have the hair something like this, the nearby sebaceous gland, they open their secretions into, so this is sebaceous gland, right? So if there is any blockage over here, the secretions, they will remain pent up. So that is acne, and this presents with comedone. It can be white or black, depending on oxidation to, because of exposure to atmosphere or not, right? So this is acne vulgaris, and for nodulocystic acne we can try isotretinoin, but again this is teratogenic, so just make sure that the lady is not pregnant before giving this, right? Then moving forward to atopic dermatitis. Now we are using the word atopic, so it has something to do with, allergy. So here there is a classical at times family history of asthma, right? Even in the patient there can be a history of asthma, so this is related to atopy. Now there is so much of itching that this condition is also known as itch disease, and in different age group different areas of the bodies are involved. Like in children and adolescent, there is involvement of the body flexures like elbow, knee, right? So this is elbow and this is knee, clear? So body flexures, or what you call body folds. Now apart from this, we can see perioral pallor. Peri means surrounding, the oral is mouth here actually, so surrounding the mouth there is whiteness. But what is more important for you to remember from exam point of view is the Denny Morgan line. So please remember Denny Morgan line, and this is actually an additional fold of skin beneath the lower eyelid, right? So this is the Denny Morgan line or Denny Morgan fold, very important. Then there might be increased palmar markings, and the best way to diagnose atopic dermatitis is clinical evaluation, right? So there is Griffin and Rajka's criteria, and that is based on clinical findings. Then moving forward to Acantholysis nigricans, you can see this black dark pigmentations in body folds, especially the nape of neck or in axilla also. So there is dark thick velvety skin, especially in body folds and creases. Usually it is associated with type 2 diabetes mellitus. Sometimes they don't give you type 2, they can simply write metabolic syndrome, so you should know this as well. And very rarely it can be an indicator of internal malignancies like adenocarcinoma lung or carcinoma of stomach, right? So it can be stomach. So this is although rare, so it can be an indicator of internal malignancy. So it does not mean that if you see somebody with Acantholysis nigricans, you should straight away jump to this. It may be associated with obesity or type 2 diabetes, right? So right, then moving forward to alopecia, which is loss of hairs, and there are two classes. Either it can be scarring or which is known as cicatricial alopecia. It can be seen in Lichen planus, DLE or lupus vulgaris, but most important is the alopecia areata, right? So you can see there is loss of hair at a localized site. So this is localized area. So alopecia areata, this is non-scarring variety or non-cicatricial variety, and what we see classically is a exclamation mark here. Now what is this? Now if you look at the normal hairs are like this, right? So this is base and this is tip, but what happens in exclamation mark here, the hairs are something like this. So this is the exclamation mark here, broader above and tapering below, clear? So this is exclamation mark here, and please remember it for alopecia areata. Now moving to shingles, which is reactivation of herpes zoster virus, especially in cases of HIV, and again you can see here grouped vesicles. Okay, so you can see the vesicles in groups. So this is grouped vesicles, which is always very characteristic of herpes lesions, and we can see redness, so that is known as erythema, erythematous base. And this particular is seen along entity is seen along one particular dermatome, clear, and this is unilateral, only on one side. So very easy to identify clinically, and yes, we need to give antivirals like acyclovir or famciclovir. Then moving forward to leprosy, we can use 3 drugs: rifampicin, clofazimine and dapsone. Of course, in multibacillary we give all these 3 drugs. In possibacillary we give only one and the third, so rifampicin and dapsone. For neuritis, we can give steroids. If there is abscess, it needs incision and drainage. Most common nerve is ulnar nerve. Now Mycobacterium leprae bacilli, it prefers cooler places, right? So it does not involve warm areas. So it does not involve warm areas, which is like ovary, lung, CNS or axilla. So warm areas are not preferred. So it does not involve all those areas which are warm. It prefers cooler areas like skin, nerve, right? So that's why we see majority of the discussion in terms of skin and nerve, right? The infective form is lepromatous leprosy, and we do one lepromin test. Now again, this is not a diagnostic test, clear? It is not a diagnostic test, it is prognostic, and it checks actually immunity. So we have 2 spectrums. On one side we have the tuberculoid, right, and on the other side we have the lepromatous. So immunity is good here and poor here, right? So this is the spectrum, which includes borderline varieties as well. So total there are 5, but these are at the end. So lepromin test is good and it checks actually cell mediated immunity. Now lepromatous leprosy is very easy to identify. The moment you look at the face, this is a classical face, leonine facies. You will see nodularity of skin, involvement of the most areas of the skin, right? If you look at the breast in males, it will be enlarged, gynecomastia. Then you can see there is loss of eyebrows. This is madarosis. And at times, if you see the nose, there is saddle nose, which is collapse of the nasal bridge, right? So this is the collapse of the nasal bridge. Then madarosis is eyebrows. Now on histology, we can see foamy histiocytes and very few non-caseating granuloma, because this is more suggestive of the tubercular leprosy. Just basic difference between the 2 varieties. Lepromatous is quite easy to identify. You will see a person with disfigured face, that is leonine facies, right? The earlobes will be very big, saddle nose can be seen, CMI is poor, so negative lepromin test. And then there might be ulnar nerve involvement, which present to you with partial claw hand, right? So here you see this is the classical saddle nose, okay? This is leonine facies, very easy to identify. Now tuberculoid, it usually presents with a single skin lesion. So there is a well demarcated dry patch, right? So in simpler terms, we can say it is a single skin lesion. But what happens, because of formation of granulomas in the nerve, there is loss of sensation in that, so there will be anesthesia. So if you see a single skin lesion which has well defined margins, especially and more importantly, if there is no skin sensations, you should suspect tuberculoid leprosy, right? And there is no disfigurement of face, no claw hands, no problem with the earlobes, and good CMI, so positive lepromin test. Then there are 2 lepra reactions. Type 2 lepra reaction is erythema nodosum leprosum. So this is erythema nodosum leprosum, and this is actually type 3 hypersensitivity reaction, that is immune complex deposition. Here we can give thalidomide, but again drug of choice is steroid. Now type 1 is type 4 hypersensitivity reaction and it needs steroids as well. Then wood lamp, the light generated is 360 nanometer UV rays, and the filter is made up of nickel and silica. Especially in cases of erythrasma, if we do wood lamp examination, we will classically see coral red appearance, right? So this is for erythrasma. Clear? Then moving forward to tuberculosis of skin, there are two varieties. One is lupus vulgaris, where there is primary involvement of skin. Clear? So there is no underlying active foci like in bones or lymph nodes. But sometimes what happens, there is TB of lymph nodes, or you can say bones, which involves skin secondarily. This is known as scrophloderma. Clear? So this is the basic difference between the two varieties. Lupus vulgaris, no underlying structure involvement, and in scrophloderma, it is actually the TB of the underlying structures which is later on involving the skin secondarily. So two varieties of TB skin. Then Staph aureus can lead to many conditions in skin. One is of course staphylococcal scalded skin syndrome, right? So staphylococcal scalded skin syndrome, and scald means skin injuries because of hot fluids. Then bullous impetigo or impetigo contagiosa, and you can classically see honey colored crust, classical presentation. Then there is furuncle or boils, which is involvement of hair follicles. Then there can be psychosis Barbie or psychosis especially involving the beard area. Clear? Then moving forward to Reiter syndrome, which is also known as reactive arthritis, because it can occur secondary to two set of conditions. Either there is a chlamydial infection, which is sexually transmitted entity in case, and secondly it can be because of some infectious dysentery which may be caused by Shigella or Uroplasma urolithicum. So either of the two conditions will be present, and then only the patient will go into Reiter syndrome. So either there is a chlamydial infection of the genital tract, or there is infectious dysentery. Now the features can be remembered like there is urethral involvement, so urethritis, there is conjunctival redness, so conjunctivitis, and there is involvement of joints, so that is arthritis, right? And there can be you can remember the mnemonic like CUA, so keep it over here. So this is Reiter's syndrome. Then it is associated with actually B27. Then some conditions are there, like one important is tuberous sclerosis. Here you need to remember three important terms. One is of course the ash leaf, right? So this is the ash leaf spot. Then adenoma sebaceum and shagreen patch. So remember these three terms for tuberous sclerosis. Then pinch purpura, it can be seen in secondary amyloidosis. Okay, so it seems as if somebody has pinched here. So this is pinch purpura, and this is secondary amyloidosis. Lichen planus we have already discussed. Remember Wickham striate, civet bodies, and also Max Joseph space. Then for atopic dermatitis, please remember Denny Morgan fold. Pityriasis rosea, please remember Herald patch or mother patch, and annular collarate of scales, right? So I think this is enough for dermatology from exam point of view, and I'm very sure you might have enjoyed the session.